For the past 1 year, apart from other activities, I have been requested by my wife, Professor Dr.S.Chandrasekharan, to come twice a week to the Devaraj Manichand Memorial Maternity Hospital. Devaraj Manichand Maternity Hospital is one of the well-known hospitals in the local area, but less well-known hospital in the city of Chennai. They have got a huge load of obstetrics and gynecology, and they have developed only one specialty, obstetrics and gynecology. Dr. Chandrasekharan felt the time has come that one single specialty hospital without the support of other specialties will no more be valid in the modern delivery of healthcare. And she has been requesting many persons from Stanley Medical College to come and visit the hospital. Many of the physicians have visited. I thank all of them for building up a good department of medicine there. Subsequently, when everybody has decided, I have been requested to come there. Of course, it's all on charity basis where I am going. I learned a lot there. The hypothyroidism in pregnancy is an example where laboratory medicine has completely overtaken clinical medicine. The adverse effect documented by various researchers and scholars of both hypothyroidism effect on the pregnancy and fetus, overt hypothyroidism on the fetus is enormous. They have also demonstrated very convincingly, as they demonstrate in diabetes, that is, you have got the diabetes in pregnancy, the child develops diabetes at the age of 15 years. They have very clearly demonstrated that if we keep the maternal blood hypothyroidemia, hypothyroid, the mental development of the child at the age of 6 or 7 years is definitely below par compared to the lady who has delivered a child with a normal thyroid hormone. It is a very well established fact over the past 50 years by many studies, and this has given trust that laboratory medicine overtakes clinical medicine. Secondly, this development of laboratory medicine used to the researchers in laboratory medicine, where they have developed a very accurate method of measuring TSH. TSH measurement has been now done in the 4th generation, where the accuracy is very, very high compared to the many other tests. Because we have got a very accurate method of measuring the thyroid status, now we have now come to diagnose hypothyroid state in pregnancy, not only by clinical methods. Of course, I am not saying clinical medicine to be discarded, but apart from clinical medicine, the universal screening of a pregnant woman for thyroid has come to be a dictum today. Therefore, every pregnant woman or aspiring to become a pregnant woman should test her thyroid function. And the two common laboratory tests that are done are TSH and free T4. In this also, the researchers come to a definite conclusion that the TSH value applicable to a pregnant woman is lower than the TSH value applicable to the normal population. The normal laboratory value for the 3rd generation is 0.35 to 5.5 microunits by milliunits per ml. But by the 4th generation, it's slightly lower. And whether you measure the THS by the 3rd generation testing or 4th generation testing, the value 2.5 and above should be treated. This is one of the dictums that has been developed universal consensus that in treating hypothyroidism in a pregnant woman, the THS value should be kept at 2.5 and slightly below. And also, the fetal maternal outcome of overt or covered hypothyroidism has got many ramifications, that the pregnancy, throughout the pregnancy, as you keep the blood glucose at a very controlled tight level, the thyroxine level also should be kept at a tight, controlled, normal level. Now, another thing that has been found, that the requirement of thyroxine increases as the pregnancy advances from the 1st trimester to the 3rd trimester. Or if the lady is already hypothyroid diagnosed in the non-treatment of thyroxine, when she becomes pregnant, the requirement goes up. Therefore, it becomes mandatory in the pregnant woman to assess thyroid function every 3 or 4 weeks and then adjust the dosage. As it progresses from the first trimester to the third trimester, the thyroxine dosage increases and reaches a peak, and subsequently after delivery, fortunately over a period of 6 weeks, the thyroxine requirement comes down. This is the second big term, which even though it is theoretically given in the books, I relearned myself after practicing a heavy load of hypothyroid patients in the Northwest. I don't know whether it is related, that's not the part of the subject. The hospital caters to more than 50 to 60% of the local Muslim population, caters to around 20% of the local Jain population, and caters to 20% of the other Tamil-speaking population. The hypothyroidism is very rampant in the area. Another thing in this management of this hypothyroid patient, they have developed the guidelines, pregnancy guidelines. First and foremost is universal screening, which I have already mentioned. Therefore, every antenatal woman should have their basal values of the thyroid function to be well documented. Second, in selected cases, there should be TPO, thyroid peroxidase antibodies, should be tested. Now, what are the cases to be tested is when you have got a maternal family history of thyroid dysfunction and apparently the girl is normal. Apparently the girl is normal. The recommendation is to test the TPO, thyroid peroxidase. It's a new name for the original antigen used to test, and that should be measured. That also now, the laboratory measurement is increasing in its accuracy in giving us the diagnosis. This is the second guideline. The third guideline is, it is better to slightly over-treat the thyroid patients than under-treat. Because the dosage which we recommend maximally reach 25 microgram, 50 microgram in a period of 8 to 10 months, fortunately does not lead to thyrotoxic state. Fortunately does not lead, because it is a young result. After pregnancy is determined to be 10 months only. And at the end of 10 months we are going to de-link the mother and the child. And hence we have to be slightly on the higher level of treatment. This is the third guideline. Then another thing that has been very clearly demonstrated is, like the insulin hormone, the counter-regulatory hormones are anatomical structures that destroy the iodine are very many in the pregnant patient. For example, the placenta is a destroyer of iodine. But unfortunately, we don't have a direct measurement to determine what the placenta does. We have only the maternal blood to analyze. Therefore, by necessity, a frequent testing is repeatedly has been called for, which I have already mentioned. Therefore, the basic management of a hypothyroid patient in the pregnant woman is first a universal screening. Second, a low TSH value to be treated. 3, high normal or even apparently normal person with a family history of thyroid to be going for antibody testing of TPO. In that case, the treatment is very simple. Very, very short course of steroid, not very high dose. Very, very short course of steroid, say for example, prednisolone 2.5 milligram in the evening single dose for 2 to 3 weeks. That's nothing more than that. Because prednisolone, steroids are very harmful to the pregnancy. Therefore, we are not in a position to give the steroids. But if you find the TPO titers more than 200%, you should give us one. And there's increasing requirement of thyroxine throughout the pregnancy, and the requirement of thyroxine after the pregnancy comes down. Therefore, postpartum monitoring for 6 weeks is mandatory to stabilize the patient. These are simple facts which I relearned. I thought I would share with you. And in this process, it's a nice thing that most of the companies have come out with 25, 50, 75, 100, 1.5 milligrams, because the tablet is so small that breaking and giving them damages more, and accuracy of the treatment comes down. And our GlaxoSmithKline, who are the sponsors of the day, have also fallen in line and brought in 25, 50, 100 micrograms. These are the few points I thought I'd share with you. Any questions, I'll only happy to answer.
After delivery, can we stop the tablet?
6 weeks we have to monitor, sir, and then only stop the tablet. 6 weeks, that's the direction. gain.
For hypothyroidism, we require only TSH level.
No.
Why do you ask for free T4 to rule out hypothyroidism?
I only mentioned THS because one of the successes of laboratory medicine is a very accurate measurement of THS. From that point of view only, I highlighted TSH. Because it has become a very reliable thing if done properly. But mandatory free T4 and TSH. But what I find in the field condition is, most of the laboratories who are serving us are doing all the three. Free T3, free T4, free THS. And free T4 is very useful to assess the autoimmune thyroiditis.
Thank you, Professor Chandrasekharan. I think you were telling about Gujarati Hospital?
Yes. No, not Gujarati. Unfortunately, that is not in the good shape. There is another main hospital which is in Sokat Pet.
That's good.
Sokat different. Gujarati also is different. This, they have been only doing osteopathy, very good hospital. And fortunately, sir, I cannot tell it openly. The load is as good as from Chandrasekharan College. Because taking everything from that hands-on experience and go to the hospital.
Professor Chandrasekharan has given a valid take-home point that we have to estimate TSH and rule out hypothyroidism in all cases of pregnancy. I would like to add that hypothyroidism is also quite common in diabetes. That too, subclinical hypothyroidism. That's why whenever we screen the patient for diabetes as a whole, we always include TSH, and we have found a lot of cases for having elevated TSH along with the diabetes. The hypothyroidism symptoms and signs develop very late. It has to be the TSH is reduced, TSH is elevated, and take some time for the reduction of T3, T4. Then only the clinical symptoms are present. So nowadays we don't depend on the clinical features for diagnosis of hypothyroidism. And another thing you were telling about is TPO antibody that is usually present in Hashimoto's thyroiditis. And if the patient has TPO positive, I don't know how this short-term steroid therapy will help. Of course, you have a condition.
Recommendations, that's why I don't estimate because you usually have to give a longer time. Pregnancy situation you can't give.
Yeah, pregnancy, that's the one which handles. But probably to come over the acute thing, we can give steroid, and then after delivery, we have to continue steroids for a long time. Thank you.
I will add only one point and close. The scenario in elderly is entirely different. In the elderly, please don't over-treat with testosterone because they are going for some other problem. We will take it up for a lateral session. We relearn all these things by studying, you learn again and again.